Okay, thank you very much attending in the 2023 Global Webinar Series number 4 and run by an IPC. My name is Akimichi Morita. I'm from Nagoya, Japan. I'm a board member of International Psoriasis Council, IPC. That is international group of psoriasis experts that organize educational program virtually and in person worldwide. So we will start in the current knowledge and the future directions, psoriasis and the gut for the today title. So please look at the housekeeping. We will have 60 minutes and please pay attention for the point, okay? So we'd like to start in this webinar series in number 4. So I have to explain about what is an IPC. And so about IPC, founded in 2004, the International Psoriasis Council, IPC, is a dermatologist-led, voluntary, global, non-profit organization with a network of more than 150 psoriasis experts through leaders and the professionals dedicated to improving patient care around the globe. In the vision, our vision, of course, to improve the care of people with psoriasis worldwide through research, education, and advocacy. So people with psoriasis, no matter where they live in the world, no matter how complex their symptoms, should have access to the best care available to them, and that ultimately a world without psoriasis is possible. So there is many global networks, psoriasis experts, 155, one global board member of councils representative, 37 countries. IPC councillors are appointed by the IPC board based on their expertise in the psoriasis. IPC board members and the councillors volunteer their time to implement all IPC programs and activities. 86% participated in the IPC activity during 2022. So, and we have at least 2 an IPC event. Please save the date. And especially 2024, May 7th. And we have a meeting and IPC Global Education Day and comprehensive care of psoriasis and held in an AD, San Diego Convention Center room at 23 ABC and 2 to 6 p.m. And also, it's the most important part of it in a psoriasis from Gene to Clinic International Congress will be held in London and the Queen Elizabeth II Center, UK. So I'm invited tonight for me, and for other people for morning, probably in the afternoon, invite 3 people, 3 experts for this field and psoriasis, and also the inflammatory and gut syndrome. So, and Dr. Francis Lai from Monash Health and Skin Health Institute, Melbourne, Australia, and 2023 IPC Fellow. And also, I have invited, it's quite a famous immunologist in Japan, and Professor Kiyoshi Takeda from Osaka University, Affleck, Osaka, Japan. And also Dr. Alex Tsoi, and he work in University of Michigan, Ann Arbor, Michigan, United States. So all the experts, we will expect into great, excellent talks, and also probably we have a lot of knowledge insight from their talk. So agenda, you can see that, and also explain later time on, and we have 3 sessions, and finally, I would like to have a panel discussion, and please please put in your Q&A by the chat. So I can put in a question from you, from of course from each and the talks, and also panel discussion. Please put your comment or question to the chat. So I would like to start. And first one, the title is Genetic Insight into IBD and psoriasis, IBD and psoriasis should feature unique characteristics. So I would like to introduce Dr. Tsoi. Dr. Tsoi joined the Department of Dermatology at the University of Michigan in 2015 as a faculty. He's interested in investigating complex cutaneous disorders, pathology, and genetic architectures using systemic biology approaches. Recent study from his laboratory identified molecular components showing heterogeneity among psoriatic patients and revealed shared and unique genetic component between psoriasis and its comorbidities. Okay, Alex, and share already shared screen. Okay, and please start.
Thanks for the introduction, Dr. Marita. So it's really my pleasure to talk with you all today. I'm going to give you some overview about some shared genetic components between IBD and psoriasis, and then how we could go from here to try to leverage some information for potential translation application. So this is my disclosure. So psoriasis patients can experience like different types of comorbidities, including cardiovascular conditions, diabetes, or different other immune conditions. So IBD is also one of the comorbidities that include Crohn's disease or ulcerative colitis or CD or UC. They're like common subtypes of IBD. There are like different epidemiological studies have been conducted trying to understand the associations, and we're showing like some of one of the recent studies that show the odds ratios for occurring psoriasis with CD or UC is around like 1.7 based on this study. So the electronic health records over the past 20 years have really facilitated the collection and also literature analysis of a lot of these disease relationships. Okay, it provides a really cost-effective way to conduct epidemiological or even genetic studies. So this study that we just got accepted yesterday, actually. So we try to look into the comorbidities of multiple different skin diseases by looking into a claim database that include over like 13 millions of individuals over the past 10, 20 years in the United States. And I'm just going to give you some quick overview what we find. So this is like number of psoriatic patients that we have looked into, like over 200,000 psoriatic patients. And we also have like 48,000 of psoriatic arthritis. So for the psoriatic patients or the psoriatic arthritis patients, we try to compare their comorbidities rates when comparing with the like normal control individuals. And here are the different diseases or conditions that we have looked into. Red color representing they occur more than expected. The blue one representing they occur less than expected. You actually see that like Crohn's disease or ulcerative colitis among the two that have the higher odds ratios when compared to other conditions. So both IBD and psoriasis are complex diseases. The common conditions it represents there's a lot of interplay between multiple genes or loci with environmental factors. So each individual locus would actually contribute modestly to the disease, but then there would be like many different components across the genome. So in order to identify these genetic variations that are associated with either IBD or psoriasis, if different studies have been conducted independently in the past. So for IBD, over 200 loci have been identified. And then for psoriasis, from a recent paper, that over 100 loci have been uncovered. So this genome-wide solution studies, the concept is that trying to, for each genetic variant, we try to compare the allele frequencies in the cases versus those in control and identify those genetic variants, those that disease-associated variants that have a big difference between cases and control. So then that's like a long journey from where where everyone started and to now what we know about the shared genetic signal. So when we first started, try to do the psoriasis GWAS or other investigators trying to do the IBD GWAS, they look into the regions that have been identified by associated with the trait, okay? And then they try to see in some of the early studies, try to just looking into the overlap, okay? So this is just an example. We did this we did this GWAS like over 10 years ago, and then we identified multiple different loci, and then that time we were interested in saying, well, within this particular locus, have this also been identified in other disease, just but simple disease overlap. Okay, and you can see that then there are multiple different loci at that time that shows overlap. You see Crohn's disease here, so other conditions here. So again, this is like just simple overlap, and then you could look into this figure asking, well, for loci that are associated with psoriasis, what are their notable genes in that locus that are also linked to other like comorbidities that are also complex condition. Okay, so this is like one of the earliest way, and then another study that actually published in the same year, on the same year, they try to combine the psoriasis GWAS and IBD GWAS and try to look into like doing like a meta-analysis kind of study and to use that to map some disease share signals. And this is actually pretty cool. Then you could actually see how some of the genes that are encompassed in some of the shared loci are involved in the IL-23 or IL-17 signaling pathway. So that now I just mentioned about like the shared loci, but are they the same signal? Are they just like overlap but not in the same signal? So I introduced you to like this colocalization analysis. So this has a history in trying to interpret the GWAS signal by using expression connected trait loci association. Okay, so basically you could ask, well, if we have two different traits, and then so the x-axis representing the genomic position, the y-axis representing the statistical significance level. So are they kind of like co-localized, together? If they are co-localized together, that means that they are sharing the same signal. If not, they may be just two independent signals within the same region. Okay, so a study that just conducted this year did this. Okay, you can see the x-axis here was an IBD US signals, and then the y-axis here is psoriasis US signals, and then they show that some of those shared loci are indeed co-localized, and this is highlighting the IL-23 locus, seeing that the pattern, the LD patterns actually co-localized with each other, suggesting they are actually indeed the same genetic signal. So after looking into this like genetic signal share list, what other things that we could do by using statistical genetics or the genetic information? In the last 4 to 5 years, this statistical genetic technique called Mendelian randomizations have been conducted. So rather than using only disease incidence, okay, the Mendelian randomization technique try to use the genetic markers that randomly distributed among population to model to model one disease, like for example exposure, and then use that model the disease to in turn, okay, conduct a linear regression on the effect size for the other disease, like the outcome. Okay, so using this approach, you could actually infer potential causal relationship. And then a study that published last year conduct this Mendelian randomization using over 400,000 European individuals, and they try to use that to infer the causal relationship. So what they found is that the genetically predicted IBD, okay, so you're using the genetic variants that associate with IBD to model the IBD as exposure, is actually associated with high risk of psoriasis and psoriatic arthritis, as shown here in that figure. But on the contrary, when you try to use the genetic signals to model psoriasis and psoriatic arthritis, they do not find any causal effect on the IBD. So in conclusion, there's existing GWAS link that show shared genetic regions between psoriasis and IBD. Okay, using more advanced techniques and also high resolution genetic map, we could infer some causal relationship, and also not only asking whether they are shared genetic regions, but also whether they are shared signal or between IBD and psoriasis and as such, which is looking to like IL-12/23 signaling pathway that's shared, and this could potentially could help us to translate some of those genetic findings to clinical settings by predicting drug response if we also integrate with genomic information. Yeah, that's all for my talk. Thank you. Have you take any question?
Thank you very much. And Alex, it's a great talk. Very much excellent insight. So I think I would like to ask the attendants, and if you have any question from the audience, please put your question to the chat or by the Q&A. I'm sorry, Q&A. So Q&A, not chat in a Q&A. You can find at the bottom in a Q&A. Okay, I think it is not no question at this moment. So I would like to ask you, is there any related to the efficacy to added FER123, P90 or P40 antibody? So from your result and conclusion, so can we consider the treatment for if patient have IBD and psoriasis, if the patient has both psoriasis and IBD, or just psoriasis alone, or just PSA alone, or PSA and comorbidity in IBD?
Yeah, well, that's a great question. I'm not a clinician, so I'm not sure the best answer for treatment. But then from our so we also study psoriasis and other comorbidities, like including type 2 diabetes. And we do find that for those individuals that have psoriasis and type 2 diabetes, they have the risk loci that are shared between the two conditions in a higher, risk allele frequencies than individuals just have psoriasis or just have type 2 diabetes. So I would extrapolate that and say that, for those individuals that suffer from both IBD and psoriasis, they may also have a little bit more unique genetic profile in their IL-23 signaling loci than individuals that just have psoriasis or just have IBD. But yeah, no, that's a great question. And yeah.
Okay, thank you very much. Okay, we will have another Q&A, and it's the final part of it, 10 minutes. Okay, please join again, Alex. Thank you very much. Great talk. So I would like to start in a second lecture. The title is Immunopathogenesis of IBD and Pathway to Therapeutic Change Challenges. And will be presented by Professor Kiyoshi Takeda. I would like to introduce Professor Kiyoshi Takeda. Professor Takeda is director and professor at the Immunology Frontier Research Center, IFRAC, at Osaka University. His research activities focus on understanding the pathogenesis of inflammatory bowel diseases. Particularly, they analyze how intestinal homeostasis is maintained by the mucosal immune cells and epithelial cells. And he published many great papers, including Nature and other important journals. Okay, Professor Kiyoshi Takeda shares. Okay, you have already shared screen. Okay, please start your talk.
Okay, so Aki, thank you very much for the introduction. And I'd like to appreciate Aki for providing the opportunity in this nice IPC webinar series. But my research field is not the dermatology, but the mucosal immunology. And so today's talk, it will be focused on just the pathogenesis of the inflammatory bowel diseases. But I hope all of you follow or enjoy my talk. So, recent several evidence have indicated that both the genetic predisposition, particularly intestinal immunity and intestinal microbiota, both contributes to the pathogenesis of the inflammatory bowel diseases. So indeed, the complicated interaction between the intestinal immunity and microbiota contributes to the development of the inflammatory bowel diseases. But between this microbiota and intestinal immunity, as you can see in this slide, between this microbiota and intestinal immunity, there exists a single layer of the intestinal epithelial cells. So we hypothesize that these intestinal epithelial cells have some barrier functions that separate the intestinal microbiota and the intestinal immunity. So in this regard, epithelial cells of the gastrointestinal tract are covered by the mucus layers. Compared with the epithelial cells in the stomach and small intestine, epithelial cells in the colon are covered by the very thick mucus layers that are composed of the outer mucus layers and the inner mucus layers. So what is the outer and inner mucus layers? So when we stain the microbiota and MAC2 mucins in the mouse colons, so actually red stained microbiota are really abundant in these outer mucus layer regions. But when you see these inner mucus layers that are visualized with these MAC2 mucins, these inner mucus layers are essentially free of this red stained microbiota. Thus, by the presence of this inner mucus layer, microbiota is separated from these host cells. So regarding this, the mechanisms for this separation of the intestinal microbiota and the host cells, general concept so far accepted was that because this mucus are really slimy, this slimy mucus mechanically prevents the invasion of the microbiota. But I simply wonder if this is only one mechanism. So in this step, my PhD student Liu addressed these issues by focusing on the molecules that is selectively expressed in the large intestinal epithelial cells. So actually he found LYPD8 molecules. When we analyzed mRNA expression of this LYPD8 in several tissues, LYPD8 is expressed only in the gastrointestinal tract, particularly in the cecum and the large intestine. So when we analyze the LYPD8 mRNA expression in the large intestine, LYPD8 is expressed in the epithelial cells, but not in the lamina propria cells. Thus, this LYPD8 is selectively expressed in the epithelial cells of the cecum and the large intestine. So he decided to analyze the function of these molecules. And then he generated monoclonal antibody against LYPD8 and analyzed the protein expression of the LYPD8. So mouse colon was fixed with this continuous fixation method that can preserve the luminal contents and can be used for the immunohistochemistry. So in this case, LYPD8 was found to be highly expressed in the uppermost layer of the colonic gland. And further, this molecule was found to be secreted into the intestinal lumen. So to visualize the outer and inner mucus layers, microbiota was also stained. So in this case, LYPD8 was found to be accumulated into this interface between the outer and inner mucus layers. Thus, LYPD8 was highly expressed in the uppermost layer of the colonic gland and secreted and accumulated to the interface that are exposed to the microbiota. So this is the case for the mouse colon. We then analyze the human colons. In the case of the human colon was fixed with a classical PFA fixation method. So in this case, luminal contents were all washed out, and this area was seen just blood. But when we see the LYPD8 expression, again, this red stained LYPD8 was found to be highly expressed in the colonic gland, uppermost layer of the colonic gland. But when we analyze the ulcerative colitis patients, LYPD8 protein expression was severely reduced. Thus, LYPD8 protein expression well correlates with the pathogenesis of the ulcerative colitis. So, our next question is the role of the LYPD8 in the colon, and go back to the mouse studies and generated knockout animals. So again, in the case of the wild type colon, bacterial-free region can be observed just above the colonic layers. But when we analyze the LYPD8 knockout animals, red stain microbiota attach or invade into the colonic tissues, although the MAC2 mutations are normally present. Thus, in the absence of the LYPD8, bacteria became to invade into the colonic tissues, and these LYPD8 knockout animals were highly sensitive to the intestinal inflammation. So to summarize these LYPD8 studies, LYPD8 was expressed on the uppermost layer of the colonic epithelial cells and secreted into the intestinal lumen, colonic lumens. And then LYPD8 binds to the flagella of the flagellated bacteria. Actually, these kind of the flagellated bacteria are highly motile, and LYPD8 binds to this flagellated bacteria and suppress their motile activity. In the absence of this LYPD8, these highly motile flagellated bacteria invade into the epithelial regions, which increase the risk of the intestinal inflammation. Thus, LYPD8 is essential for the separation of the microbiota and the epithelial layers, and important for the maintenance of the intestinal homeostasis. Thus, intestinal microbiota are present within the intestinal lumen without directly attaching to the host cells. This kind of the separation is required for the maintenance of the intestinal homeostasis. But all of you know that these kind of the intestinal microbiota influence the host cell functions. In this respect, bacterial metabolites, particularly short-chain fatty acids, are well known to act on the host immune or epithelial cells. So we simply wondered if other bacterial metabolites also act on the immune cells. So in this regard, we focused on the unique subset of the intestinal myeloid cells that are characterized by the high expression of CX3CL1. This CX3CL1 high myeloid cells are present just beneath the intestinal epithelial cells, extend their dendrite into the intestinal lumen, and directly uptake the luminal antigens, and subsequently activates the effector T cells. So my PhD student Naoki tried to identify the bacterial metabolites that is responsible for the extension of the dendrites of this CXCCL1 positive myeloid cells. And he found that microbiota-derived lactate or pyruvate, this lactate or pyruvate induced the dendrite extension of this CXCCL1 positive myeloid cells through the G protein coupled receptor GPR31. So microbiota-derived metabolites mediates the host microbiota interaction for the maintenance of the intestinal homeostasis. But our interest is the pathogenesis of the inflammatory bowel diseases. So we wondered if microbiota-derived metabolites are also involved in the pathogenesis of the inflammatory bowel diseases. So Hisako and Yuriko addressed these issues, and they first performed lipidomic analysis of the patients with the inflammatory bowel diseases, particularly Crohn's diseases. And they found that lysophosphatidyl So the concentration of the lysophosphatidyl was increased in the plasma of the Crohn's disease patients. So depending on the saturation status, there are at least two types of the lysophosphatidyl but the concentration of the both lysophosphatidyl was increased in the plasma of the Crohn's disease patients. So in addition to the plasma, we also analyzed the concentration of the lysophosphatidyl in the feces. So again, both types of the lysophosphatidyl was increased in the feces of the Crohn's disease patients. So this lysophosphatidyl was generated from the phosphatidyl by the action of the enzyme called phospholipase A, PLA. And this PLA was expressed in the host cells, and actually PLA was also expressed in some kind of the bacteria. Because lysophosphatidyl concentration was increased in the intestinal lumen, so we wondered if this biosis altered the composition of the microbiota correlates with the increased concentration of the lysophosphatidyl in Crohn's diseases. And we performed the shotgun sequencing. And we found that in the Crohn's disease patient, actually Crohn's disease patients have the dysbiosis, and in which the bacteria possessing the PLA genes was increased. And accordingly, concentration of the lysophosphatidyl was increased even in the intestinal lumen. So our next question is this lysophosphatidyl whether this lysophosphatidyl is involved in the pathogenesis of the intestinal inflammation. So we address this question using the mouse models. So immunocompromised LAG2 knockout animals, when transferred with naive T cells, they developed mild intestinal inflammation. And 17 days after the naive T cell transfer, lyso-PS was administered. Administration of this lysophosphatidyl induced severe weight loss rapidly and induced severe immunopathology, indicating that this lysophosphatidyl exacerbated the intestinal inflammation in these T-cell dependent colitis models. So at this time point, 21 days after the naive T-cell transfer, we then analyzed the T-cell numbers in the intestinal lamina propria. So T-cells, actually CD4 T-cells were isolated from the colonic lamina propria, and analyzed for the number of the interferon gamma producing Th1 cells or the IL-17 producing Th17 cells. So after the lyso-PS treatment, the number of the interferon gamma producing Th1 cells or interferon gamma and IL-17 producing pathogenic Th1 cells was significantly increased. Thus, lyso-PS treatment induced the increase of the Th1 cells and exacerbated the intestinal inflammation. So our next question is the lyso-PS directly acts on this CD4 T cells. So we performed the in vitro experiment. Naive T cells were isolated and cultured in the Th1 polarizing conditions. And one day after this culture, lyso-PS was added to the cultures. So addition of the lyso-PS increased the number of the interferon gamma producing cells. So in this experimental condition, only Th1 cells were existing, indicating that this lyso-PS directly acts on the Th1 cells and activates the Th1 cells. So when we stimulated naive T cells with lyso-PS, this lyso-PS did not act on the naive T cell at all. Thus, lyso-PS just acts on the Th1 cells directly and activates the Th1 cells. So we then analyze how this lyso-PS acts on the CD4 positive Th1 cells, and then we try to identify the host receptors. So the host receptors for the lyso-PS was already identified, and these are actually the G protein coupled receptors, such as GPR34, P2Y10, and this is a pseudogene in the mouse, and GPR174. Among these G protein coupled receptors, when we analyze the expression of Th1 cells, P2Y10 was found to be highly expressed in the Th1 cells. So we analyze whether this P2Y10 is involved in the lyso-PS or pathogenesis. So we generated P2Y knockout and P2Y10 knockout animals and used this LAG2 knockout animal or colitis models. So LAG2 knockout mice were transferred with wild type naive T cells or P2Y10 knockout naive T cells. So transfer of the wild type naive T cells induced the mild development of the mild colitis, and they showed the weight loss. But when transferred with the P2Y10 knockout naive T cells, nothing happens, and these LAG2 knockout mouse are totally healthy. And up to the 20 days after the naive T cell transfer, lyso-PS was administered. In the case of the LAG2 knockout animals transferred with wild-type naive T cells, lyso-PS treatment rapidly decreased their weight and induced very severe pathologies. Thus, in the case of the wild-type T cell transfer, lyso-PS exacerbated the intestinal inflammation. But in the case of the LAG2 knockout animals transferred with the P2Y10 knockout naive T cells, lyso-PS treatment did not induce anything. Thus, lyso-PS acted on the Th1 cells through the P2Y10 and worsened the severity of the intestinal inflammation. So I'd like to summarize. So in the Crohn's disease patients, they have the dysbiosis in which the increased number of the microbiota which possess the PLA genes, and accordingly, concentration of lysophosphatidyl was increased. And this lysophosphatidyl directly acts on the Th1 cells through the P2Y10 receptors and further activates the Th1 cells, which leads to the exacerbation of the intestinal inflammation. So I'd like to acknowledge that these contributors of these studies. So actually, these studies are mainly performed on Naoki and Liu and the Hisako, under collaboration with the clinical department of the Osaka University. So thank you very much for your attention.
Okay, thank you very much. A great talk and also excellent and lectures. And thank you very much, Professor Kiyoshi Takeda. And two questions from in a Q&A. And one, can LYPD8 be used as a probiotic?
Oh, yes. So actually, we generated recombinant LYPD8 protein and orally treated with the colitic mice. So treatment of the oral treatment of this recombinant LYPD8 rescue the development of the intestinal inflammation. So if we could generate large amounts of the recombinant LYPD8, they can be used for the therapeutic approach.
Okay. Is there any of the clinical trial or?
Actually, we discussed with the pharmaceutical companies, but for the oral treatment, so many amounts of the recombinant proteins required, they say. So actually, at this moment, pharmaceutical companies are not interested in this approach.
Okay. And the second one is, would you say that the increase of lysops depends on specific type of bacteria in the intestine?
Oh, yes. So I do not mention exactly, but particularly E. coli possessing the PLA is specifically increasing in Crohn's disease patients. So actually, there are several types of the E. coli. When we analyze healthy controls, E. coli do not possess these PLA genes. But when we analyze the Crohn's disease patient, E. coli possessing the PLA genes was increased. I guess that this kind of the E. coli have some pathogenic functions in Crohn's disease patients.
Another question, do you think it depends on the diet or mostly in the microbiota signature of each individual patient?
It's a very good question, but at this moment, we do not know how the dietary habits are correlating with this dysbiosis at this moment. Thank you very much.
Okay, thank you very much, and very good answer. Thank you very much. Okay, we will have last part of it, about 5 or 10 minutes discussion. Okay, thank you very much. Okay, the final presentation in a case study, the complex relations between IBD and psoriasis. And Dr. Francis Ray, okay, I would like to introduce Francis. And Dr. Francis Ray is a dermatologist at the Psoriasis Biologics Clinic at the Skin Health Institute and Monash Health in Melbourne, Australia. He's a sub-investigator in multiple psoriasis clinical trials and is actively involved in psoriasis education advocacy. Dr. Ray is a 2023 IPC Fellow and studied with an IPC board member, Ricardo Romiti, at the University São Paulo, Brazil. Okay, you have already shared screen. Okay, please start, Francis.
Thank you for the kind introduction, and thank you, Akimichi and the IPC for this opportunity to present at today's global webinar. So I will be talking about a case study, which I hope will be a good discussion point for us to launch into, to looking at the complex relationship between inflammatory bowel disease and psoriasis. These are my disclosures. So the patient is a 46-year-old Caucasian lady who weighs about 72 kilograms and has had psoriasis for over 20 years with a pretty severe baseline PASI of over 20. Of note, she has no significant family history, in particular, no family history of psoriasis or inflammatory bowel disease. She's otherwise very fit and very well. She takes Ventolin for her occasional asthma, And she does suffer from occasional vaginal thrush and does take fluconazole every 2 to 3 months for mild episodes, which settle pretty quickly. She works in administration. So for the first few years of her psoriasis, she mainly treated it with a combination of topical therapy and narrowband UVB. And then her psoriasis gradually started to worsen, and there was a thought to look at whether we do commence a biologic therapy. In Australia, biologic therapy is subsidized by our government, but you do have to try back then in 2015, you had to try 3 traditional treatments and fail to improve before being funded for biologic therapy. So as a result, she tried methotrexate and then cyclosporin, and subsequently was commenced on ustekinumab. And this worked very well for her, and she had significant improvement in her chronic plaque psoriasis, and a PASI dropped down to 0.3, so pretty much nearly clear. It was noted in her clinical records that she did have a bit of mild lower back pain in 2019. However, in 2021, this really started to worsen more, involving the lower back and also the right hip. It sounded very much inflammatory in nature, with early morning stiffness and worsening upon prolonged periods of no movement, such as when she sat down for a long time or when she was standing for a long time. And it was really affecting her quality of life. She was having trouble exercising and also affecting her sleep. She tried seeing a physiotherapist, and also taking non-steroidal anti-inflammatories. And subsequently, she was referred to rheumatology, and she was noted to have mild enthesitis of her left Achilles as well, suggesting a diagnosis of psoriatic arthritis. As a result, she was switched across from ustekinumab, an IL-23 agent, to secukinumab, an IL-17 medication. And this helped very well for her axial psoriatic arthritis symptoms. And we know that certainly, although many medications, many of the biologics are indicated for psoriatic arthritis, the IL-17 groups do have a slightly higher efficacy and evidence for axial disease. Pleasingly, she had no increase in vaginal thrush, and this still occurred quite infrequently. However, her skin continued to persist in stubborn areas. Most of her skin improved, but the lower legs continued to have quite persistent plaques, as we can see here. And this obviously continued to impact her as it limited what clothing she could wear, especially over summer. She persevered with secukinumab for 10 months, but eventually the decision was made to switch across to ixekizumab. And she had a very good response to ixekizumab, with complete clearance of her skin with a PASI score of 0, and her axial disease remained quiescent. Unfortunately, when we continued on monthly ixekizumab dosing, she developed abdominal pain, diarrhea, urgency, and occasional blood in the stool. And this would occur every single month after each injection for several days, sometimes up to a week. The thoughts were potentially that this could represent inflammatory bowel disease, and so she was referred to gastroenterology. And a biopsy of the terminal ileum was suggestive of ulcerative colitis. She was commenced on sulfasalazine and cortisol suppositories, which were helpful, but she definitely was not particularly pleased with having these symptoms, and eventually it was decided that we switched across to a TNF adalimumab. And this resulted in complete resolution of these monthly bowel symptoms, and she was able to stop those medications that she was put on for her ulcerative colitis. And pleasingly, she continued to have good control of her skin with a very low PASI score, and her axial disease was also quiescent, and she did not have any symptoms of psoriatic arthritis whilst on adalimumab. So this is a summary of the case at this point. But I guess the challenges and learning points, and I guess this ties in quite well with Dr. Kiyoshi and Dr. Alex's talks, in that when we see this in a clinical setting, we have to consider, as Alex mentioned, all these comorbidities that are quite commonly seen in our psoriasis patients, and does make it quite challenging in terms of choosing the right medications that we have. I think in this case, some learning points that I took from it were that failure of one IL-17 certainly does not preclude the use of another, and this is certainly supported by quite a few reviews that have been published in the JAD. As I mentioned, with the IL-17s, there's certainly a role in psoriatic arthritis, especially with axial disease. And I guess something that we could discuss further in the next part of the webinar is, this role between IL-17 and inflammatory bowel disease, whether this case does represent an induction of inflammatory bowel disease, or whether this is more of a association that we see in psoriasis is still debatable, and there are many studies that have shown conflicting results, whether it be that these were odd occurrences of inflammatory bowel disease developing or exacerbated on IL-17. So I think certainly something that we could discuss further. Thank you very much.
Okay, thank you very much. And it's quite interesting and case, thank you very much, Francis. And any question from Q&A or chat? Okay, one from me. So this indicates, the patient had developed IBD, like IBD by the IL-17 inhibitors, or patient have already have some basics, some and proceeding, okay, some latent or IBD, or is there any opinion, or maybe just paradoxical reaction like the 17 inhibitors?
Yeah, no, it's a really good question. I don't think I have the answer for it. I mean, certainly there are many literature reviews looking at this association between inflammatory bowel disease and IL-17s, and there are certainly case reports of induction or exacerbation of potentially latent symptoms, as you mentioned. I thought what was interesting with this case was that when she was on secukinumab, she had no inflammatory bowel disease symptoms, and it was only when she switched across to ixekizumab that she developed inflammatory bowel disease symptoms, which were biopsy confirmed and very much consistent on histological diagnosis. So yes, I don't have an answer for your question. It's a bit unknown in terms of her case, whether she may have had mild latent symptoms that were crumbling away that were eventually triggered, or whether this is truly a IL-17 induced case.
Okay. Is there any other biomarker for that case? That is the case, like psoriasis, IBD. So is there any biomarker for?
Not that I'm aware of. I think some centers do check for fecal calprotectin, but I was looking at her notes. I don't think she ever had this tested beforehand or during her bowel symptoms, but certainly that would be interesting, and whether that's something we screen for even, but certainly not in her case, unfortunately.
Okay, thank you very much. It's now we should think about it. And eye probably, and also we think IBD and many of the comorbidities around the psoriasis and the skin diseases. So one of the important point is IBD for tonight, so for today. So I really thank you very much for your talk. Okay.
Francis, actually, I have a quick question. This is Alex.
Okay,
Do you
please,
know whether the patient's family has any IBD?
No, so in her case, that she had no family history of psoriasis or inflammatory bowel disease or any other autoimmune conditions. But yeah, that's definitely a very relevant question.
Thank you.
Okay, thank you. So we still have a few minutes, and we should have a panel discussion in at least in 2-3 minutes. But we still have a good question from Q&A question from audience, for Professor Takeda, Kiyoshi Takeda. Okay, and it was noted in paper that lyso-PS given intralectally in comparison to IP triggered more severe colitis in the mice model. Is the pro-inflammatory effect transient or provocate T-cell priming permanently?
Mhm. Oh, yes. So thank you very much for reading our paper. So actually, for the lyso-PS treatment, we first performed the intraperitoneal injection. But when we administer lyso-PS through the intrarectal route, so in this case, lyso-PS effect is more potent. So I believe that the lyso-PS present in the intestinal lumen is important for the activation of the Th1 cells. And so the question is that this effect is transient or permanent. So this should be the very important question. But when lyso-PS was administered, mice suffered from the very severe intestinal inflammation. So we should stop the experiment. So I do not, at this moment, I do not observe the long period after the lyso-PS treatment. So this moment, I could not exactly answer this question, the effect of the lyso-PS is transient or the permanent, but the lyso-PS acts on the Th1 cells and change their intracellular metabolic status. So this kind of the effect would be the very transient, so it's not permanent. So I suspect that this effect of the lyso-PS was just transient on the Th1 cells, but at this moment, I do not have the exact evidence. Thank you very much for the question.
Okay, and a final question probably for you. Is there any evidence on the protective effect on the IL-17C on the boil mucosa? IL-7C effect in the protective effect of IL-17C on the boil mucosa.
I guess this question is for the Francis. No?
Probably, yeah. Yes.
I don't have too much experience with IL-17C. I think it's still something that's, from my understanding, being investigated in terms of its role with inflammatory bowel disease. My understanding is that it does play some function in terms of the barrier of the intestinal membrane. But I think with the medications in our case, both secukinumab and ixekizumab, IL-17A blockers. So yes, only I think worth looking into IL-17C further in the future in terms of whether it's a target or plays a role in the disease.
Okay, thank you. Okay, thank you very much. And that's the time in about 1 hour. So, and thank you very much, and 3 speakers, and really excellent, and also very much educational. And also I have learned a lot from 3 speakers. So I would like to conclude in webinar 4, in the global webinar series 4, is the current knowledge and future direction, psoriasis and gut. So we have a lot of knowledge from these 3 speakers. So, and I hope you have any question, and please put your some part of it into the IPC. And also, if you join later time on, you can see a video and from the IPC site. Okay, thank you very much for your attendance, and thank you very much to 3 speakers. Okay, thank you very much for tonight.